So I'm very happy to introduce Dr. Holm. He is a staff physician at the Allina Health System and in the GREC at the Minneapolis VMAC. With over 30 years of experience in the evaluation and treatment of acquired cognitive impairments in adults, he's founded and directed the Cognitive and Behavioral Disorder Program at Bethesda Hospital in St. Paul for more than 27 years with services including inpatient neuropsychiatric evaluation in the treatment unit, an outpatient diagnostic and management clinic with an electroconvulsant therapy program. Beginning in 2020, he served as the clinical director at the GRACE program at Regina Hospital in Hastings and has assisted in the development of the clinical programming with the Allina Healthcare System to better address the needs of adults in the community suffering from cognitive and neuropsychic disorders. So let's give a warm welcome to Dr. Holm.
Thank you and good morning, and I'm very pleased to be here and very pleased to give my first presentation in person in more than 3 years, so it's really cool to be here. Okay, so for the next 45 minutes, if I can get through it in that amount of time or next hour, I'm going to talk about the evaluation and management of behavioral disorders in the cognitively impaired older adult. I have one disclosure. Not surprising. We know that behavioral and psychological symptoms of dementia or neuropsychiatric symptoms represent a healthcare crisis in our community. And this is something that we've known about for 40 years. We'll talk a little bit about that. But the demographics, I think we all know. What we may not know is that neuropsychiatric symptoms represent a marker of neurodegenerative disease. In fact, patients with behavioral disturbances in dementia may represent a separate clinical entity. And we'll talk a little bit about that. Untreated neuropsychiatric symptoms accelerate the advancement of neurodegenerative disease, increase morbidity, increase mortality, increase healthcare costs. So these are really a sign of trouble to come for people that have these problems. And by the way, I was a fellow in the GREC at the Minneapolis VA back when the GREC had fellowships. In the 1980s, we were talking about the impending epidemic of Alzheimer's disease. And the thought at that time was that we were going to need to, in those days, train more doctors in obtaining the clinical skills to evaluate and manage acquired cognitive impairment and behavioral problems in late life. What we didn't realize in those days was it wasn't so much an epidemic of Alzheimer's that was going to be a problem. It was going to be an epidemic of neuropsychiatric illness. Alzheimer's disease, in the absence of neuropsychiatric illness, certainly is a challenge, but not nearly the challenge that we see when behavioral problems begin to emerge. Just as a, just to give a little more background, I was principally trained in internal medicine, and the GREC had a fellowship with the intention of training internal medicine doctors in the science and art of dealing with these problems. Now, that didn't last, and as a result, when I go into a practice setting, people are very surprised to hear that I've been trained in internal medicine, but I do shock therapy. But the reality was that we felt that there was this imperative, and what's happened is that we failed. I mean, the number of care providers going into the areas of medicine that deal with these problems has been going down, not been going up. So today we have one geriatric trained MD for every 10,000 geriatric patients. Okay, the WHO sets a standard of 10 per 10,000. Okay, and in our country we have 30 MDs per 10,000 as a whole. So we haven't trained enough providers, and it shows. Forgive me here. The other point to be made here is that healthcare systems and payers have not made the appropriate adjustments in the way we provide care and in how we're reimbursed to provide care to encourage the establishment of effective systems for the assessment and treatment of these problems. That's one of the big problems we run into. We're trying to fit a square peg, that is a neuropsychiatrically impaired older adult, into a business model that, that is really geared for other problems, right? So one of the things that I've always puzzled over is this, this problem, that we still train doctors in the trichotomy of medicine, a development of a way of organizing medicine that was maybe more fully developed by the late 19th century, but in those days, average life expectancy was 47 years. When we were an adult back in those days and we developed a medical problem, it was much more likely we were going to fall into one of the silos of medicine, neurology, or psychiatry. Today, life expectancy, of course, is much greater, and now we're seeing this Venn diagram begin to emerge, where we still see people that will fit into the silos, but more and more we see people that lie at the interface. They have problems in all three areas. And this leads to a lot of confusion. You know, who takes care of these problems? And who considers the medical implications of psychiatric care? And who considers which medicines are going to interfere with medical treatments? The people that lie at the interface, these are the people that are the 30-day outliers within hospitals. They're the 30-day readmits, right? They're the people that are in and out of emergency rooms. And these are the people that we really are challenged with, and this becomes more and more of a problem as we go forward. So, what are behavioral and psychological symptoms of dementia? Well, the International Psychogeriatric Association has given us, I think, an adequate way of defining it. It's kind of clunky, but it is, as it is stated here, and what I've listed are examples of neuropsychiatric symptoms that we're all well aware of. Most of these come from Jeff Cummings' Neuropsychiatric Inventory, but these are the problems that populate our clinical experience in patients with acquired cognitive impairment. What about the prevalence of these problems? Now, this is data that was published, cumulative data from 48 studies on the prevalence of neuropsychiatric symptoms in Alzheimer's disease. And it's telling us what we already know, and that is that they're prevalent. We see them a lot. And some of the more destructive behaviors tend to be very prevalent. What about the prevalence of neuropsychiatric symptoms as a function of stage of dementing illness? There have been a number of studies that have looked at this. They all tend to show us the same thing, and that is that we see neuropsychiatric symptoms throughout the entire course of a dementing illness. We certainly see them before people begin to show acquired cognitive impairment, but the more problematic and dangerous or destructive symptoms tend to occur in the middle stages of illness. Okay? So we see more of them as we go from an early clinical phase of illness to moderate stages of illness, and then they begin to wane a little bit in late stages of illness. My thought has always been that in middle stages of illness, we have patients with just the right amount of cognitive disability, but they still retain enough ability and functional ability to get themselves into trouble. Now, in late stages, it may be that we can't see the problem because they can't act out, you know, they can't walk or whatever, but we see more problematic behaviors in middle stages of illness. This is likely because most patients by this stage of illness have frontal subcortical impairments. Okay. What about the phenotype? What do we see in terms of neuropsychiatric illness as a function of stage of dementia? In the early clinical phases of illness, and generally I'm speaking of Alzheimer's disease, we tend to see fairly mild symptoms. We see apathy, which we talked about a little bit here not too long ago. We see mild depressed states, and we see anxiety. When we get to moderate to late stage illness, that's when we start seeing the things that really cause trouble. We see agitated behavior, violent behavior, psychotic states, and so on. So not only do the number of neuropsychiatric symptoms build as a stage of dementia, but they become more severe and more problematic. Is BPSD a risk factor for the advancement of neurodegenerative illness? Yes. Okay, so when you see patients who have neuropsychiatric symptoms, they're likely in a category of illness where you're going to see more rapid advancement. What about death rates? Well, people with neuropsychiatric symptoms die at a faster rate than those who don't have these symptoms. Now, this is from the Cache County data, but clearly shows that not only do you advance more rapidly to severe dementia, which was defined in this study as a mini mental state score below 10, as well as increased death rates. Is BPSD a marker for neurodegeneration? The short answer is yes. Okay. Patients with mild cognitive impairment, very commonly when we see these patients, the first thing we want to know is, are they going to advance? Is this a static neurocognitive disorder, or is this the first stage of a advancing neurodegenerative disease? If you have neuropsychiatric symptoms at a mild cognitive impairment stage of cognitive impairment, you're much more likely to advance to a dementia level of impairment. We know that BPSD is associated with an accelerated rate of deterioration. We know that patients with Alzheimer's disease who have BPSD in the mild stages of dementia have a higher burden of A-beta deposited in their brain. And if they're psychotic, they have a higher burden, maybe 4 to 5 times the burden of tau and A-beta. So it does beg the question as to whether we may be dealing with maybe a subset of Alzheimer's disease. Or just know that Alzheimer's disease, I think at this point in time, we're pretty convinced it's not one illness. It's a family of illnesses, and this may be one way to segregate them. So what I put here at the bottom is that neuropathologically, it's becoming clear that BPSD are clinical manifestations of the neurodegenerative process and not simply an emotional response to illness. So you probably have all had this experience. Well, Mr. Smith, I've looked at your diagnostic tests, and I'm going to diagnose you with Alzheimer's disease, and I also think you may be depressed. And the son who's sitting there will say, well, gosh, doctor, who wouldn't be depressed? He has Alzheimer's disease. And of course, we know that plenty of people with Alzheimer's disease don't become depressed, right? We used to say that they age gracefully. They do pretty well. They just need a little bit of help. But these illnesses are not because the patient realizes that they have a terrible illness. I mean, they develop an anosognosia very early in the course of their illness. They don't think they have a problem, okay? So when you see these problems, you're looking at a person who's likely going to advance more rapidly. They likely are going to become more and more problematic in terms of providing care. And it's imperative that we treat them, because we know that if we treat these problems, we can improve their function and quality of life and reduce the morbidity and likely the mortality as well. So when we're faced with a patient with a behavioral problem, we have to begin to organize our thinking, right? How are we going to approach this problem? And so there are structured evaluation and interventional models that help us to do that. And all these do, again, is help us. Hello?
Come on in just a second. Try again. There you go.
Yeah, I want to step up here a little bit so I can look at my slides. I'm showing you 6 different models of how you might begin to organize your thinking when faced with a patient with neuropsychiatric symptoms. The first 3 models are what I'm calling unimodal models, meaning that these models are generally have been advocated in terms of developing a non-drug or non-pharmacologic treatment program. And the last 3 are what I'm referring to as polymodal, where we might use non-drug and drug therapies or other treatments. The first model is the behavioral model. The behavioral model posits that dysfunctional behaviors have antecedents, and those behaviors result in consequences in terms of the environment. And for us to help patients who have these problems, we have to understand what the antecedent is. If we intervene in the antecedent, that we can prevent the behavior. The second model here is called the unmet needs model. This model posits that many patients with dementia can't coherently communicate their needs. And it's that unmet need that results in behaviors. And so if we can understand what they're trying to tell us, we can prevent the behavior. A good example, what's a good medicine for agitated behavior in Alzheimer's disease? I get asked that a lot. And the answer is, well, if the patient is depressed, maybe an antidepressant. If they're psychotic, maybe an antipsychotic. But if they're constipated, it's a laxative. So the unmet need, okay? The third model here is the TIME model. This is an acronym, the Targeted Interdisciplinary Model for Evaluation and Treatment. This is a fairly elaborate process whereby one can develop predominantly non-drug interventions to treat older adults in long-term care settings. We'll talk a little bit more about that in a minute. Okay, polymodal strategies. There's the DICE method. This is the describe, investigate, create, and evaluate model. There is the Wisconsin STAR method, which looks at 4 areas of influence on BPSD. This is kind of an adaptation of the biopsychosocial model of understanding psychiatric illness. And then the last model is the interventional domains model. Now, all of these have been published except the last one. The last one is my model. Okay, I developed this over time in an attempt to give families and care providers a better understanding of how we provide evaluation and treatment for their loved one with acquired cognitive impairment. The interventional domains model has 3 domains. The first are disease-specific therapies, therapies that are targeting the illness that is resulting in the problematic behaviors. A wellness domain, here we're treating existing problems in a thoughtful way. That is a way that considers that the patient has cognitive impairment. You know, there are many medical problems that if we treat and don't consider the cognitive status of the patient, we may make them worse. In this domain, we're going to identify and treat emerging problems, good diet, activity, routine to one's day. All the things that we wrap into a wellness program, important for all of us, become more important as we get older, and certainly more important as we get older and suffer from chronic disease. And then the last domain here is an environmental and social interventions component. Here, it's all about the physical environment, how the caregiver interacts with the patient and others. Okay, it is these 3 domains that represent the treatment program for any patient that we have with acquired cognitive impairment, whether we realize it or not. But what I do with this model is I begin with the current treatments for the patient who is behaviorally disturbed as a starting point for the generation of hypotheses for how we can intervene in treatment to help them perform better. When they're doing well, we can well imagine that we're doing well enough in all 3 areas. When they're not doing well, then we can ask ourselves the question, where might we be falling short here? Could it be environmental, which very commonly it is? Could it be a medical problem? Could it be the cholinergic therapies creating trouble? And so on. Just a slide just for your edification here on both DICE and TIME. And the same thing here with the DICE approach. Again, no magic here. It's just a way of giving you some grounding in terms of how you can begin to organize your thoughts. Now, this is a study published not too many years ago utilizing the TIME model. This was, I think, 36 long-term care facilities in Norway. Half of them got TIME and half of them got a standard model. And they looked at 4 primary outcomes. The first was the agitation score from the NPI. The second here is the Cohen-Mansfield Agitation Inventory. The third, the Cornell scale for depression in dementia. And the fourth is the QOLID, or Quality of Life Monitor. And what they showed, predominantly non-drug interventions reduced the scores, that is, improved the patient in all 4 areas. So there is more than anecdotal evidence to support the idea that we can treat neuropsychiatric problems without medicines or other treatments. Let's see here. So we've talked a little bit about what the problem is and how morbid it is and how to begin to think about the problems. When we're thinking about treating patients who have these problems, we have to establish what our goals of treatment are. Okay, now I've listed 3 here that I use. The first goal is what I call the restorative goal. Here we're going to eliminate and or acceptably reduce the dangerous and or dysfunctional behaviors while preserving cognitive and functional performance. This is the home run, right? We're not turning mom into a zombie. We're going to get rid of their violent behavior, and they're going to think better, and they're going to function better. Second goal is a comfort goal. Here, we're going to eliminate or acceptably reduce the dangerous and or dysfunctional behaviors while trying to promote the patient's comfort. In this goal of therapy, we may sacrifice cognitive performance and function to some extent. You know, we don't have to, but we might, insofar as attempting to provide comfort. And then the third goal here is an acute or rapid control goal. Here, the goal is to eliminate the dangerous behaviors so as to keep the patient safe. You know, we'll see people in acute inpatient treatment programs that are absolutely dangerous. They're going to kill themselves or hurt somebody, and we just have to kind of put them down. So in this goal, we're just going to eliminate the dangerous behaviors, and we're not going to worry about function or cognitive performance. Once we've controlled the patient, then we can reassess. But those would be what I consider to be provider goals. What about families and caregiver goals? They have goals too. And research will tell us routinely that what families want, one, they want us to diagnose the patient. They want to know what their loved one has. And as many of you know, diagnosing somebody with dementia is about as helpful as diagnosing someone who's short of breath with shortness of breath, right? So they want to know what the problem is. They want education in terms of the treatment of their loved one, as well as the illness they have. And the third thing that they want is they want ongoing care from a competent care provider, which I think most of us are and most of us can achieve in this area. The fourth goal is something that I've seen in my years of practice, and that is that caregivers want a restorative outcome. Everybody wants a restorative outcome. What families want, though, is that they want us to try and preserve the things that remain in their parent or loved one that remind them of who they are, right? They don't want us to sacrifice that. And I'm here to tell you that and I'll show you data here, the vast majority of patients that you see with these problems can be treated in a restorative manner. It is not, I shouldn't say not hard to achieve sometimes, but we can achieve it in the overwhelming majority of patients. And frankly, in the majority of patients, we can achieve it without using anything other than non-drug therapies. So, what's a practical approach to the assessment, then, of neuropsychiatric symptoms, or BPSD, in dementia? I've broken it into 4 steps here. The first is we establish a diagnosis. This is becoming more and more important as we become more aware that the etiology of dementia will provide us a lot of useful information with respect to how best to manage the patient. So we have to diagnose the patient. Secondly, we want to perform a history-present illness on the dysfunctional behaviors, all the things that we might do for chest pain or abdominal pain, we're going to do for behaviors. Third, we're going to consider the interface. Remember that. You know, what are the medical implications? What are the neurological implications of illness and treatment on the behavioral status of the patient? Maybe we're over-medicating the patient. Maybe they're acutely confused because of the therapies we're providing. Maybe there is something with respect to the patient's behavioral status prior to neurodegeneration that has some import in what we're seeing today. Okay? And then fourth, with all of this in mind, we're going to generate a hypothesis or hypotheses regarding the etiology of the behaviors. And then we want to know this. Do the relevant dysfunctional behaviors taken in total suggest a neuropsychiatric syndrome? That is, are we going to treat the behaviors collectively as an illness, or are we going to separate them and treat them as target behaviors? We'll get into this here in a moment. I've been teaching doctors in training in these areas for over 25 years. And one of the things that is really amazing is that many doctors in training don't know how to do a differential of dementing illness. They know how to do it for AFib, they know how to do it for high calcium, but when it comes to cognitive impairment, they really don't know how to do it. I think the reason that is that the vast majority of patients fall into one of four categories, right? They have Alzheimer's, Lewy body, FTD, or vascular disease, and these illnesses have a pretty specific clinical presentation. But the reality is that when we see a patient with acquired cognitive impairment, we need to do a differential. And the reason is that there are more than 100 illnesses that fall under the rubric of dementia. And the point of doing a differential is to narrow the number of illnesses under consideration. So I've done one slide on the differential diagnosis of dementia and put the most important points here. So in approaching this, the most important point is the timing of onset of symptoms. Okay, that will most greatly reduce the number of illnesses that you have to consider. And I've broken it down into three categories. Minutes to hours, that is the acute delirium. Days to weeks, these are the subacute dementing illnesses or the rapidly advancing dementing illnesses. Usually they're going to fall into the categories of toxins, medicines, infections, and metabolic derangements. And then the months to years, which is what we most commonly see, the neurodegenerative illnesses, as well as a few others. The second most important aspect is the clinical phenotype, how the patient presents as they emerge into the clinical phase of illness. Okay? Patients with neurodegenerative disease all begin to look alike after 5 to 10 years. They have widespread involvement of all areas of the cortex, but it's how they emerged. Was it episodic memory loss? Was it language? Was it behavior? Okay, and so on. So the most important point is the timing of onset of symptoms. The second most important is the phenotype we see. The diagnostic evaluation will be in part guided by the degree of uncertainty we might have with respect to what's going on. But this is how we establish a diagnosis, at least clinically, in patients with dementia. So I'm going to talk a lot about neuropsychiatric syndromes. What I'm talking about here are what we might consider behavioral disorders that approximate what we might see in younger adults who aren't demented, who are mentally ill. Okay, what we used to refer to as primary psychiatric illness. What we see are depression spectrum illnesses, manic spectrum illnesses, mixed mood disturbances. Many people might think in terms of a mixed bipolar, but yes, you know, these folks can have a variety of ways that they may present with a variety of mood states. Psychotic spectrum illnesses, anxiety, and very importantly, substance-induced mood disorders, generally induced by the therapies that we're providing these folks. Delirium, remarkably common. And then, I don't know that we should call this a syndrome, but we're very commonly going to see a number of syndromes at the same time. So we might see psychotic depression in the context of a chronic delirium. So we have to be aware of that. But very commonly, when we're seeing patients with these problems, we can group the symptoms into one category and begin to address it. What about target behaviors? I've listed some things here that are very common in my clinical practice. Some of these things are likely a result of the neurodegenerative process and don't reflect a neuropsychiatric illness. We generally would treat them with environmental interventions. But there are a number of things here that certainly will fall under a syndromic category. So, practical approach to the treatment of neuropsychiatric illness. I've broken it down to 4 points here. The 5th point we'll expand on a little bit as well. First, we have to establish the risk of harm to the patient and others. Okay, and we have to establish the amount or degree of emotional distress to the patient. That is, we have to get a sense of what the goals of therapy are. Do we need to control this patient right away? Do we have time? We also need to consider the venue. Can we manage this in a clinic? I had a clinic for 16 years that dealt with neuropsychiatric illness. And I can tell you, as you know, it can be remarkably challenging to try and treat a neuropsychiatrically disturbed patient with neurodegenerative disease in a clinic setting. And again, I think a large part of the problem is that the clinics were never conceived of trying to do a good job of managing this problem. They're really good if you've got diabetes or heart failure or an ear infection, but when you have neuropsychiatric problems, it can be really challenging. Second, we develop and rank order therapeutics first by establishing a non-drug intervention program. Every behavioral treatment program has a non-drug component, and that's where we want to start. Even the patients that are most violent, okay? And we're going to consider, you know, a lot of aspects of the environment and wellness here. We're going to educate the caregiver, which is probably the most important non-drug intervention to involve yourself with. Third, you know, I will say that the majority of neuropsychiatric problems can be managed without the use of medicines. Okay, and so very commonly we may start with sending the caregiver to the Alzheimer's Association just to learn about what a person with Alzheimer's struggles with and how to help them, as opposed to just getting frustrated, right? So if we're focusing just on non-drug and we establish a non-drug therapy, then we're going to move to the fourth step here. But the third step would be to generate a hypothesis again, or to rank order therapeutics based on what we believe the problem is. So we might have a patient at home with Alzheimer's disease and they're psychotically depressed. And yes, non-drug interventions are important, but we do believe that we need to begin drug therapy. Okay, and here I've highlighted the idea that we want to consider the timing in which we intervene, really both for drug as well as non-drug therapies, but really for drug therapies, and here's why. The area of treatment of neuropsychiatric illness is fraught with uncertainty. Uncertainty about what the problem is, uncertainty about how to manage it, uncertainty about whether the treatments will work. So what you don't want to do when you start treating these patients is make that uncertainty greater. So let me give you an example. I have a patient in my clinic, and I believe that they have a mixed mood disturbance with a lot of depression and a lot of and a lot of psychotic symptoms. And I tell the family, well, here's what we need to do. We need to start 3 medicines. Okay, and we start those 3 medicines, and the patient does wonderfully well. You know, there's no problem there. We pat ourselves in the back and we're geniuses. But if we start the 3 medicines and things get worse, it just makes for such a tangled mess of, you know, what's wrong here? Is it the illness? Do we need to push the therapies harder? Is it the therapies? If it is the treatments, is it 1 treatment, 2 treatments, all 3 treatments? So you want to consider the timing of onset of providing drug or other treatments to the treatment process. And then the fourth step is to establish the effectiveness. Okay, let's find out how effective the treatment is. And then I put a note here that global outcomes, you know, support both the generated hypotheses as well as the means of therapy. And here we're drifting a little bit away from evidence-based medicine. Evidence-based medicine can help us, so there's just no doubt about that in the management of these problems. But if you have a clinic where you're dealing with these problems, you know what I know, and that is that evidence-based medicine hasn't told us how to take care of that patient in the waiting room. There isn't a study that has been done or likely will be done. Okay, so you know, years ago when I used to give these talks a lot more, I might give a case example where I have a patient who is dangerously out of control. I treat them with 4 medications, and we've achieved a restorative outcome, really good outcome. And someone in the audience will say, well, Dr. Holm, how do you know that medicine number 3 is really doing anything? And my answer is I don't know that it's doing anything. But here's what I do know. Here's where the patient was when we started, behaviorally, cognitively, and functionally. And here's where they are today with global improvements. And here's the rationale for the use of these therapies. You know, empiricism in a collective sense is a much different thing than empiricism for your patient. We're not trying to prove anything when we're treating a patient. We're just trying to help them. And I think that this is one of the great problems. If we surrender entirely to an evidence-based model, we can run into trouble because there isn't evidence basis for a lot of what we do here. And by the way, advancements in psychiatry, although this is beginning to change now, were pioneered by this model, by a more rational way of approaching treatment than really an evidence-based model. So we need to use both. And then the fifth point here is very important, and that is that evaluation and management of neuropsychiatric problems in dementia is a longitudinal process. It's not point in time. We're not treating strep throat here. Once we start therapies, we have to continue to evaluate. Patients will go through phases in their neurodegenerative illness where they have neuropsychiatric problems, where those problems may be treatable with certain therapies, and then they're going to move to a new stage, maybe where they're going to have side effects from therapies, maybe where they need to have more therapy. So we never really stop. We're walking a pathway with patients who have these problems. Again, I think a distinct subset of patients with neurodegenerative disease. So these are commonly utilized environmental or social interventions. Caregiver education, everybody gets a referral in my clinic. Well, when I had a clinic, I don't have one now, but everyone would get a referral, okay, to the Lewy Body Association, to the Alzheimer's Association. There's nothing more potent. A lot of behaviors at home relate to the fact that caregivers are depressed, burnt out, and frustrated. And if they just have a little bit of coaching in how to help their loved one, they're going to get rid of a lot of these problems. Reconfiguring home environments, very commonly attempted. It's very hard to do, but this can be helpful. The problem we have with reconfiguring home environments is that, you know, we have a demented person living at home, but then we have someone at home who's not demented, okay? And their idea of what home is may be different than what their loved one needs. Interventions directed at the underlying environmental cause. Day programs are, I think, very helpful. Dementia-level long-term care programs are remarkably helpful. That's what they're there for. You know, I oftentimes, you know, would have a family member who thinks that the worst thing in the world would be that their loved one might go to an Alzheimer's unit. And what I would tell them is we have long-term care facilities, not because we have lots of families with loved ones who have Alzheimer's disease who don't love these people, right? We have long-term care facilities because they provide, when they do their job, they provide a needed intervention, and the needed intervention is environmental support. Inpatient neuropsychiatric units are a very good non-drug intervention. Now, you may find that to be surprising because if you've seen any of my patients, they seem to come out on a litany of therapies. But the reality is that we withdraw therapies from a number of people that come into these programs. Why? Because they're at home and they're acting out and they need more environmental support. And there isn't anything much more environmentally structured than an inpatient neuropsychiatric program. I put here general medical units. They're no substitute, right? Our loved ones or the people we take care of go from long-term care into an emergency room setting, and they go to a medical unit. I mean, it's one of the worst things that you can do for these folks for a whole host of reasons. I could give a whole talk on that. The other thing I might add is that geriatric psychiatry programs are probably not optimal as well. Not because our geriatric psychiatrists don't know what they're doing, but when you have these patients mixed in with geriatric psychiatry patients, it's my perception that the program isn't going to be geared toward neuropsychiatry. It's going to be geared toward geriatric psychiatry, and the neuropsychiatry patient is just an addendum. In order to get really good at treating behavioral problems, you need to concentrate a clinical experience. And that's where we seem to have walked backwards, I think, in the Twin Cities area over the past 30 years or so. Forgive me. I won't go into a lot of this. I think this is pretty self-explanatory, you know, in terms of the pharmacologic categories of therapy. Additional therapeutic modalities, electromagnetic techniques are remarkably effective. Electroconvulsive therapy, probably the most effective non-drug therapy we have. Remarkably safe, completely painless, no cognitive impairments, no functional impairments. Patients do really well. Why don't we use more of this? I don't know. I've asked the question for many years. We had an ECT program in St. Paul for 16 to 20 years dedicated to patients with neurodegenerative disease. And it was one of the most remarkable therapeutic interventions that we could provide. Repetitive transcranial magnetic stimulation, there are some studies beginning to explore its use in neurodegenerative disease. I believe it can work for some folks. I worked very hard to bring it to St. Paul. I failed in that. And then there's what's called transcranial direct current stimulation. This is coming. It's an experimental technique now, but is going to likely allow for electromagnetic therapy at home. Okay, so really pretty cool stuff. Psychotherapeutic techniques work. Oh, but my patient's too demented for them to work. No. Psychotherapeutic techniques work. And they can be given to people that are at advanced stages of illness, and they can work remarkably well. And I can talk with you offline about that. Okay. We want to talk about what are commonly used medication interventions, and I've listed them here. For Alzheimer patients with mild BPSD, acetylcholinesterase inhibitors plus or minus memantine can work. Sometimes it doesn't work. Always remember, there's an old saw that you can get the opposite of intended effect from any psychotherapeutic drug. Okay, so they don't work for all patients, but they can work very, very well. For agitation, resistive decay is combative. Antidepressants plus or minus an antipsychotic therapy plus or minus a mood stabilizing therapy. And we'll talk a little bit more about that here in a few slides. For delirium due to neurodegeneration, acetylcholinesterase inhibitors can be very effective. In Lewy body, it's maybe your first go-to treatment. Remember that, 80% of folks with Lewy body dementia have Alzheimer's as well, so they have hybrid illness. So it can work very well. High potency D2 blocking therapy can also work. Haloperidol can work. Antidepressants can work as well. Remember, in depression in late life, we used to talk about pseudo dementia, that they were cognitively impaired, and it was generally brought up in the context of being forgetful. I can't remember what the date is. I don't know where I'm at. But the reality is that cognitive impairment, it can manifest in mood disorders, can manifest itself as a delirium or acute confusion. For hallucinations, again, acetylcholinesterase inhibitors, particularly in DLB, can be very effective, plus or minus first or second generation antipsychotics. For delusions, again, first or second generation antipsychotics, plus or minus an antidepressant, plus or minus a mood stabilizing anticonvulsant. I'm going to show you some data that supports that. Acetylcholinesterase inhibitors are really good for what we refer to as systematized delusions. And what these are fixed false beliefs that are generated based on what a person is seeing. So they're seeing somebody in the home because they have Lewy body, and now they believe this person lives in the attic. And this person comes down at night and rearranges the furniture and steals my wallet. Okay, so for these systematized experiences, acetylcholinesterase inhibitors can be very effective. What I'll generally do is start them, and if we're not seeing improvement, then I'll go ahead and add a first or second, generally a second generation antipsychotic, and then we'll go from there. Anyone in the room use Tacrin? Anybody? Okay. Does anyone not know what Tacrin is? Okay. Now I'm feeling really old. Tacrin or Cognex, forgive me, I'm running over here, but Tacrin or Cognex was the first acetylcholinesterase inhibitor FDA approved. It came out in 1992. We were developing our first inpatient program that year, and I was really excited about this medicine, not because It was a cognitive medicine. But we had every reason to believe that it would be a neuropsychiatric medicine. And this is a study from 1996 looking at the effects of Cognex on one, the mini mental state exam scores here, and two, neuropsychiatric inventory scores over time. What the therapy did, and by the way, it was really hard to use. You dosed it 4 times a day. People didn't tolerate it. You had to do blood tests. It was really hard to do. But if you could get somebody to dose, the dose was the maximal dose was 40 milligrams 4 times a day. If you could get somebody to dose, they did really well with it, as long as they took it. It, again, had like a 1-hour half-life. But here is the 12-item NPI before and after beginning this therapy. And you can see improvement in all behaviors. Okay? So we've known for 30 years that these medicines are not just cognitive medicines. Jeff Cummings, who developed the neuropsychiatric inventory, wrote an article years ago, Acetylcholinesterase inhibitors, a new class of psychotropic therapy. And I think for most of us, when we think of these therapies, we should think along those lines. I think that you will see greater benefit than if you think of them as cognitive medicines. They are cognitive, and you do see improvements in scores, but it's really hard to see that in real life. What I've seen is I see better attention. My loved one is more connected. They're more present. I have seen some improvements in language and maybe some mild improvements in praxis. But really where we see the improvements are neuropsychiatric problems. You know, agitated behavior can be a problem, and we might make that worse with a therapy that's predominantly an anti-apathy therapy. But remember that apathy is the most prevalent problem in Alzheimer's disease. These people quit doing things. And these therapies can keep people at home longer, and it may be because they engage a little bit more. This was a study done a few years back looking at both cholinesterase inhibitors as well as memantine. And the point to be made is that, yeah, behaviors do get better, but sometimes they don't change and sometimes they get worse. Okay? So again, there isn't, you know, a one-size-fits-all here. I mean, we have to use our clinical judgment as to when to start and stop these medicines. I did really enjoy your talk about how to pre-prescribe. I'm not a big fan of de-prescribing therapies, but I know it does work. The problem I run into is that when it doesn't work, the folks will come to me. You know, I mean, lots of folks do well with it. But the reality is that you can see the opposite of intended effect of any psychotropic therapy. Right? I mean, Aricept can treat visions, but also you can get them as a result of their use. Okay, let me move on here. This was a study published not too long ago that looked at behaviors with both donepezil, memantine, or the combo. And what was kind of curious is memantine seemed to score better here, alone. Okay, so when we talk about, well, we have mild BPSD and someone with Alzheimer's at home, they're not on any therapies at all, we might think, start memantine, maybe start Aricept first and then add memantine. When they provided both therapies, the scores weren't all that good. I mean, they were still better, but not as good. Okay, this is a great study. This came out not too long ago and looked at this whole question about long-term use of these therapies. My patient has gotten to the point where these therapies no longer work. Well, there have been studies that seem to counteract that. I mean, this study looked at 5 years, okay, on these treatments, and what they found were sustained improvements in cognitive performance and reduced death rates. Sustained reduced death rates. Of interest, galantamine was the one therapy that seemed to most dramatically reduce advancement to severe stages of dementia. All the cholinergics did, but Reminol seemed to be the most potent. So this counters the idea that we should pull people off these therapies, you know, as they get to more advanced stages. When we started, Cognex came out in 1993. Aricept came out in 97. We got our first supply in my inpatient unit the first week of January. And that year, and for a number of years later, we saw something remarkable in our program. We probably would have 3 to 4 admits per month of patients who had been on Epizil who were withdrawn when they went into long-term care. And almost reliably, within 4 to 6 weeks, they were coming in with obstreperous behaviors. They were violent and acting out. And we got onto this, started putting them back on the therapy, and we took care of those problems. So again, lots of people can come off the treatment, but there are people that require the treatment. And sometimes long-term therapy makes sense. Okay, what about treatment algorithms? You may have seen these. I put one in your slide deck for time's sake. The short story is that they work until they don't work. But before I show you that, I'm going to show you some data that I published about 25 years ago on data collected about 30 years ago with respect to these problems. So 30 years ago, when we opened our first inpatient unit in St. Paul, these programs were referred to as behavioral ICUs. And no one knew whether a behavioral ICU could be of any great benefit. So when we opened this program, we had a database, and we studied all patients that came to the program for 1 year. It was 250 patients, and I'm showing you some of the outcomes. So I've listed here common reasons for referral to our program. Again, not surprising, stuff we see. But then, what were the diagnosed neuropsychiatric syndromes? Depression spectrum illnesses, more than half. Bipolar spectrum illnesses, what do I have, 24%. Now we're almost up to 80%, okay? 4 in 5 have altered mood states. Psychotic spectrum, only about 10%, but if we added a mood component, now we're at 40%. And then no psychiatric syndrome, about 10%. Okay? The reason I'm showing you this is because this hasn't changed. Okay, this is what we're dealing with. The vast majority of people that, and I can tell you from almost 30 years of clinical experience and working with patients on an inpatient basis, they're coming in with altered mood states, period. Now, I have to get close here. So we achieved a restorative endpoint in 83%. We eliminated the behaviors and we preserved or improved cognitive and functional performance. We didn't turn people into zombies, okay? The most common, 10% of folks were withdrawn from drug therapy. Inpatient neuropsychiatric programs are good environmental interventions. And people coming from home on treatments, in this study, we didn't believe that they needed the treatment. We withdrew them, and they did better. Okay. Let's see. I wrote here about 26% of the patients who received drug therapy got one medicine, usually an antidepressant. More than 40% received 2, generally an antidepressant and an antipsychotic therapy. And then about 25% or so got 3 therapies, antidepressant, antipsychotic, and mood stabilizing therapy. What you'll find when you look at algorithms today is that's what they do. Okay, so the take-home point here is that disorders of mood are remarkably common in these patients. Sometimes they're hard to see, but they're there. Okay. So with that in mind, then if we go to I'm showing you the Harvard South Shore program. So what do? Well, they do non-drug therapies if they're mild symptoms, and then they move on to cholinergics plus or minus memantine, which makes sense. But then what do? Antidepressant. Then what do? Antipsychotic. Then what do? Mood stabilizing anticonvulsant. Okay. If you look at the patients who come out of treatment programs who have these problems, you're going to see this. And the reason is that it works. And I think we know why. I'm going to move pretty quickly here because I have some. So we go through, and forgive me, I'm going to move pretty fast here. You know, mild symptoms, moderate symptoms, and more severe. let's see here. So this is, let's see, forgive me. So these are mild, moderate, and here we're going to go to more D2 potency, okay? And then look at this, at the bottom here, electroconvulsive therapy. I wonder why. Well, because if electroconvulsive therapy is good for anything, it's good for the treatment of mood disorders. Electroconvulsive therapy is the treatment of choice, the gold standard treatment for psychotic depression in late life, period. It can be a very good treatment for bipolar illness. It's a very good treatment for psychosis. It treats what we see. And then you know, you get real severe illness. Well, now we're going to go to a rapid control model. We're going to give haloperidol and Ativan. Okay? Yeah, I've got, what, 1 minute left? Well, I'm sorry. Got it. Okay, so what are the advantages of the algorithmic approach? A decreased hospital length of stay, faster symptom control. There's no question we do this, then we do that, and it can work. Lower rates of polypharmacy. Most of these will have one drug at a time, or one drug then stop the drug and then start a new drug. Improve caregiver and patient satisfaction. What are the disadvantages? There's a limited or absent conceptual basis for treatment. I mean, what if it doesn't work? I mean, what are we treating? I mean, if we're just following A, if not A, then B, then we don't really have a concept of what it is we're trying to deal with. And when we don't have a concept, I quoted Immanuel Kant here. You know, if we don't have a concept for what we observe in clinical practice, we're flying blind. We don't know what to do if the algorithm doesn't tell us what to do. Decreased therapeutic flexibility. Every patient's different. We have to construct a treatment program. This is going to be the longest minute of your life. Because I have important considerations here. Remember, when we're treating patients with behavioral problems, we're treating more than the patient. We're treating the caregiver. We're treating the family. I like to refer to this as the aggregate patient. Okay, we're treating the interface patient. They have more than one problem. They have a myriad of problems. Remember, don't only obtain informed consent for starting therapies, obtain informed consent when you stop them. Families don't like their loved ones being on therapy. We don't know if they work or not. If they want to stop therapies that may be a benefit, we should tell them that there may be adverse consequences to stopping the treatment. Sometimes there are. The timing of onset and adjustment of therapies to reduce confusion about what you're doing. Longitudinal evaluation and management. Dr. Holm over-medicates his patients. I've heard that, and I think I do from time to time. But when I saw the patient and they were in 4-point restraints, it took an intensity of therapy to bring them under control. When they came under control, they looked great. They were walking, they were cognitive. Then they go to long-term care, for example, and maybe the therapies aren't adjusted. 4 weeks later, they're obtunded. Okay? We know that the potency of therapy required to bring somebody under control when they're really out of control is going to be more intense than the potency of therapy required for long-term management. So it's a longitudinal management process, and we have to be sensitive to that matter. Okay, so now this is the great part of the talk. Questions that I commonly would get. Why does evidence-based medicine seem to fail to show what clinical experience seems to show with respect to the effect of medication therapies in the management of BPSD? Probably a lot of reasons, but I think the main reasons are it's very hard to study a heterogeneous population. We may control for some things, but we're not controlling for all things. The other thing is it's very hard to define these things. What is a depressed mood? What should we expect to see? How do we measure it? So it's very, very hard to show that these therapies can work in double-blinded controlled trials. Not that we shouldn't do them, and not that they can from time to time. They can, but they oftentimes are not going to give us an answer for how to treat our patient. My patient's not responding to therapies. What is wrong? I would tell families one of 3 things is wrong. 1, we have the wrong hypothesis. We think it's illness A, and it's not. 2, we have a correct hypothesis, but we don't have the right treatment. Not everyone who's depressed is going to get better with Prozac. Or 3, Reasonable hypothesis, adequate therapy, but the patient can't respond to the treatment. Remember, for example, drug therapies in the treatment of neuropsychiatric illness in these patients don't make the patients better. The brain heals itself. What the medicines do is allow the brain to do something it can't do on its own. So we're trying to encourage the brain to modulate, to heal itself. And I do believe that there are times when we have patients at very end stages of illness where maybe they don't have the neural wherewithal to heal, to respond to these treatments. Fortunately, that's rare. And I don't think it's appropriate to say, Ms. Smith, your husband's not getting better because he can't, as opposed to he's not getting better because I'm not smart enough, to see the problem as it needs to be seen. My patient responded well to applied therapies, but now is demonstrating worsening behavior and function. What is wrong? Most commonly, what is wrong is that we're not continuing to adjust the therapies based on the needs. So we got them under control. They look really good, but over the next week, they start to become more somnolent. They're not walking as well. Maybe we should reduce the treatments. Oh, I love this one. Families of my patients are angry, demanding, and impossible to satisfy. What is wrong? Most commonly, what is wrong is that we're not including the family as the surrogate, right? I mean, every patient we see is given informed consent for a treatment because they're cognitive enough to say, gee, maybe I don't want this treatment, but not our patients with these illnesses. So we have to involve the family. The other thing is that the families don't have enough support. Caregivers very commonly are depressed, so we have our work cut out for us. Okay, common questions. I found a treatment program that works well for my patient with a good restorative outcome, but the family believes that the medicine therapies used have caused cognitive and functional impairment. Consider testing cognitive and functional performance before you treat, if families are really worried, and then reassess. Remind the families that we're not treating their Alzheimer's disease. We're treating a neuropsychiatric complication of Alzheimer's disease, and try to educate them that there are aspects of dysfunctional behaviors that are really pretty, I have to quit, or? Oh. Okay.
No, go ahead and do closing comments, and then we do need to move on. It's 20 minutes past.
Yeah.
Great, this is fantastic information, and I hate
Yeah.
to end this.
Well, I'll tell you what, why don't we just end it, but if you want to go through the slides, just come on up and we'll finish. But let's see. Yeah, if you're going to withdraw therapies because there's concern about dysfunctional behaviors, get informed consent, because the families may come to regret what you're doing. Okay. Okay.